Chapter 4, Health Reimbursement Methodologies. This test will have 20 questions. They do have some math in them. We're going to review some of the math that you'll see in these. So let's get started. These are our learning objectives. There are some terms that I want us to start off with. Make sure that you know bill charge. This is the price that's assigned to a unit of health. Next is an allowable charge. That's the amount that the third-party payer or the insurance will pay. And it may be different from what is billed, because remember that different insurance companies have agreed to pay different amounts. And then payment is the amount that's going to be paid for that service. Now, in this chapter, we're going to be talking about some types of health care reimbursement. And remember that reimbursement is coming from a third-party payer. So here's a list of what we're going to be talking about: retrospective, prospective, comparing those, differentiating between. We're going to look at how diagnostic coding is used to help with risk adjustment. And then we're going to look at accountability care organizations, those are ACOs, how they make up a hybrid payment system. So again, remember that those third-party payers, that's who's paying the bill: Medicare, Medicaid, our insurance company, and that amount of payment and how they're going to be paying is determined when they're negotiating that contract. That insurance company is negotiating it between the facility and the actual insurance company. So it's going to vary by payer to payer. If we had only one plan, it'd be great. If we had only one insurance provider, it would be great. But unfortunately, we don't. So what we have to do is always make sure that we're looking at the patient's insurance plan and what their contract says as far as which type of reimbursement they have with that facility that we are working with, that we want to get reimbursement. So retrospective is a more predominant method. It's based on the actual resources that are expended. It's the total amount of resources, and they're not known until after it's been delivered. And the risk is on the payer, because the payer is going to not get paid until after the services are being delivered. So there's an established rate for each service that may be provided. And then that total is going to be a mix of the procedures and the services. There's 3 types we're going to talk about, and you need to know the 3 types of retrospective. They are fee schedule, percentage of the billed, and then per diem. In your book, on page 65, table 4-2, it shows you the characteristics of each of those. So you can kind of see a comparison, but we're also going to go through the slides where we're going to talk about each of those as well. And that's on page 65. So let's go ahead and look just a minute at perspective. With perspective, these providers receive a predetermined amount for all their services, and it is provided over a time period or an episode of care. The payments rates are established in advance, and they're fixed. The provider faces fiscal loss if those costs actually exceed that reimbursement, but they can also make a profit if it doesn't cost as much. So they're going to say, let's say a chest x-ray, they're going to say the predetermined cost is going to be $200. If it only costs them $100, then they make $100. If it costs them $300, then they will lose money. The risk is on the provider because the payment is established in advance. Now, it's not going to change. And with prospective, a plus is that there are some incentives, whereas the retrospective does not have incentives to control the cost. And we're going to look at each one of these different types. All right, so let's first of all look at the retrospective fee schedule. So this is a predetermined list of fees that the payer allows for payment for a set of healthcare services. This is our allowable charge. That's the average or the maximum amount the payer will reimburse. So remember, we had billable and we had allowable. Billable is what they can bill, but allowable is all we're going to pay. The contracting unit is the individual service. A fee schedule is usually used in a doctor's office, so it's going to reimburse that doctor for each service provided during a clinic visit. Now, have you ever gone to the doctor and at the end of the visit they hand you a piece of paper and they tell you to take it to the front? You may look at it and see where the doctor circled a whole bunch of items on it. That's where that doctor has circled those items that he did while he did your visit. So if you had a doctor's visit and then maybe let's say you got a vaccine, that's going to be circled, and then let's say maybe you got some counseling about smoking, that may be circled. All of those things have a fee schedule, which means that they have a dollar amount that is assigned to them, and each one of those services will be taken care of. Now, this one kind of sounds like that it's more of the perspective, but the problem is when I walk into that office, I don't know how many services I'm going to get, so that is what makes it retrospective. I don't know the total number of services. All I know is that there will be a fee for each one, and it kind of depends on what I actually have done as to how many of those services are provided. That's what makes it retrospective. On page 65, figure 4.1, there is a sample fee schedule. It's purple. A lot of those codes are HCPCS or CPT codes. And you will see there that they are office visits, vaccines, chest x-rays, dipstick urinalysis. So that's our fee schedule. Remember that that's where the doctor gets money for each of the services that you received as a patient during that visit. Next, we have percent of the bill charge. This is where the payer has negotiated to pay a reduced fee for services provided to the insured. So in this one, the unit is the whole claim. So it gives you an example there. It says the payer pays 70% of a bill charge. So if the charge is $1,000, then the reimbursement is $700. So again, that's $1,000 and you multiply it by the 70. These are rare and they're usually only used for cancer care and children's hospitals, but they can be used in inpatient and outpatient. They're just not used a whole lot. So on page 66, there is a sample claim that shows you how this would be used. It shows you the covered charges, and in this case, in the sample on 66, the reimbursement is 64%. So you're just simply multiplying that charge by the 64% to get the reimbursement rate. The last retrospective is our per diem. Per diem means per day. CMS uses this for inpatient psych. And so our contracting unit is the inpatient day. It can also be used in other areas, but it's usually in an inpatient setting. And again, what makes it retrospective is we don't know how many days you're going to be there. We know that you're going to be in an inpatient facility, but we don't know how many days until you're discharged that you actually will be there. This uses historical data to kind of come up with how we're going to pay for it. So it's a fixed rate, and it's a fixed rate per day. On page 67, there's some examples of the per day rate, and it does vary based on where you are and what type of treatment. Like for a patient that's in ICU, it's going to be more daily than it would be in other areas, because they're trying to make sure that they receive payment for the services that are provided. All right, so the first one that we're going to look at under prospective is capitation. And this is where the payer reimburses the provider a fixed per capita amount for a defined period. So per capita is per patient or per person. And you'll see there, here's a little bullet. And it's important you know this, per member per month. A lot of times they abbreviate that as PMPM. And what that means is they're going to get paid every month per individual that is enrolled. So in this case, the contracting unit is the person or the person that's insured. So the volume, intensity of service, it doesn't impact it. So the more services, you don't get more payment. The provider gets paid even if a person does not receive service because they're getting paid per member. So a lot of times the provider can attempt to control utilization, and they try to engage in population health. And the ways they do that is preventative care, case management for chronic disease. They do screenings, preventative care, treatment, wellness care. So a lot of that, those wellness visits and stuff like that, they're trying to control the use of the services, and also trying to prevent sicker patients by catching it earlier. There is no uncertainty for the payer, and the provider always has a guaranteed customer base. Now, the one thing with this one is that this is Medicare Advantage. So if a patient, as we talked about last chapter, we talked about Medicare. Medicare Advantage is a capitation contract. So when we think of that, it is a contract. So it is getting paid per member per month, whether they use the services or not. Over on page 69, there is a little drawing there that shows you how CMS pays per member per month to that Medicare Advantage provider, and then they can use whichever method to pay the fee schedule, case rate, or per diem to those other facilities. Next, we have a case rate. Now, with our case rate, the payer reimburses the provider one amount for the entire admission or encounter, regardless of the number of services or length of admission. This can be inpatient, outpatient visit, a same-day surgery. There's no increase in payment. It's just a predetermined amount of money, and it goes, again, by those historical resource needs, and it's based on what is a typical cost. It encourages cost control. So an example would be a case rate for pneumonia. They look at historically how much does it cost to care for a patient who has pneumonia, and they set that as the case rate amount for that, and that's how much they pay. So for an average person, that's how much it would cost. Now, what this doesn't take into account are people with chronic illnesses who come in on top of having pneumonia. They may also have CHF, they may have diabetes, and those patients are going to cost more for the facility, and the facility then loses money. So again, you can see down here at the bottom, it says they can profit or they can have loss based on providing care. And it all depends on how sick the patients are that come in under that case rate cost. Now, let's look at an example of this to kind of see what another way of looking at it. So let's say that I have a patient that they are in the hospital with congestive heart failure, and my total charge for that person was $28,000. That was the total charge, that the billable amount. But my case rate allowance was only $26,000. So the difference is $2,000 in what I billed and what my case rate is. So in essence, that facility lost $2,000, and there's no way to recoup that. I can't send a bill to the patient saying, hey, you have to pay me this $2,000 because your insurance didn't. That's just a loss on that facility / provider for accepting the case rate. And then they have to hope that the next pneumonia patient they have, maybe when they take care of them, it doesn't cost them the $26,000, so they make money up in another way. Sometimes people say with this that it can lead to care that may not be sufficient, just because they're trying to control costs so much to prevent loss of reimbursement, which is kind of easy to see. Next, under perspective, we have the global payment. The global payment is a single episode of care payment. This again is looking at one episode, so the payment is for everything. So the example that it has there is dialysis. So with a global payment, it pays for the dialysis equipment, the supplies, any labs, and any drugs. It also talks about something that you've learned about in your coding, which is our global surgical package, which is the OR, the anesthesia, the pre-op, post-op follow-up. Another thing that this would fall under this would be our OB, where it pays for prenatal delivery as well as our postpartum charges. Now, in some cases, if that care is provided by other people, it may be split up. But in most cases, it should be provided by the same provider / facilities. And there is a figure 4.5 that shows you how it is a savings for global payment for the provider for reimbursement payments. That's on page 70. And that's global payment. Last is our bundled payment. And this is also by episode. This to me is real similar to the global payment because you have a predetermined payment amount that is provided for all of the services that are required. So it's a lump sum payment. This can be different providers that are providing, and it can be looking at different conditions. One thing that this does look at is CMS's CJR model, which is a joint replacement model. They say that with this, that there's a trigger, and that trigger leads to an episode. And so what's paid for is that trigger as well as the episode. And it does include days, number of days. And it does have a predictable pathway that goes along with it. So that's the difference in the bundled and the global, is that it has that trigger and then it has the number of days. Otherwise, it's real similar to the global pathway. So here is the disadvantages to each. Retrospective, few incentives to control cost. little incentives to order less expensive services. It rewards the providers for more services regardless of whether services are warranted. Prospective creates incentives to substitute less expensive procedures and tests. It creates incentives to delay or deny procedures. And then premature discharge in the inpatient setting can occur. So again, remember when you're picking your insurance, these are things that you want to look at to pick what you most want in your plans. So next we have something that's called risk adjustment coding, and this is our CMS hierarchical condition categories, CMS-HCC. It uses demographic characteristics, health status to predict future healthcare expenditures. Again, kind of fancy. Uses demographic characteristics and health status to predict future healthcare expenditures. So know what it is. It was implemented in 2004. It's used with Medicare Advantage Part C. It helps to provide fair and accurate payments while rewarding efficiency and quality care. It works with the Department of Health and Human Services to develop risk models. Now, what is a risk model? A risk model is looking at how sick are you and how much is your care going to cost. We look at it this year to determine how sick are you going to be next year. The higher your risk score is, the more it's going to cost to take care of you. And when we're looking at that, we're comparing it to the average person. So what we do is we say, you've been this sick this year, based on the risk, you will be this sick next year, and it's going to cost this much to take care of you. So we can actually adjust how much your insurance is based on your risk for being sick, as sick, or sicker next year. Kind of tricky there, huh? They're looking at how are you going to maintain your health. So, there is table 4-4 on page 73 that kind of shows you some comparisons of some ICD-10-CM codes and some HCC codes. There are some principles that are listed on 73 that go along with how we create the models and how they create that risk schedule. Don't get too hung up in that. Most of that is done with a computer. We don't do a whole lot with that. Do know that it primarily uses ICD-10-CM. So again, this is what we're looking at here. We have our ICD-10-CM code. So we have the beginning of the year, patients are treated, documentation is coded, the HCC ICD-10-CM codes are identified, your health status is established, your payment rates are set, and it goes around in a circle. So the year before is what we call your prediction year. The year that this is looking at is called your base year. So we have a base year, which is the first year. And then the next year, what we're doing is looking at your risk. So if you look at page 75 in your book, figure 47, it shows you. So it's got a list there of ICD-10 codes. And then it's got HCC codes. And you will see that those codes are assigned risk scores. And then it also looks at your age and your health status, and it assigns you an overall risk score. And there's two examples there. There's patient A has a 1.065, and they had salmonella, sepsis, severe sepsis. They had contact dermatitis, COPD, essential hypertension, infective bursitis. And then the other patient has a 1.559, and they looked a whole lot sicker to me. They got osteoporosis, they've got chronic kidney disease, endometriosis, type 2 diabetes, atrial flutter, anemia, nightmare disorders. So that is how they are determining. Now, going on to our next slide. In order to have good codes, you have to have high quality provider documentation and well-trained coders. And these are needed in order to make sure that we're pulling out the correct CM codes so that we can then do our HCC documentation. So there's a lot of education that needs to go on, and then there's a lot of monitoring of that documentation. So this here, it says C figure 4.7, but it's actually 4.8. So let's look at that just 1 minute. So it gives us two scenarios. The first side of that column is a poor documentation. And then the same patient on the other side is good documentation. So take just a minute and look at those two different documentations. You can kind of see one side doesn't have a whole lot of writing, whereas the other side does. So when I look at the first side, the only CM code I picked out of there was an N40.1. And you can see it says no HCC. Now, as a coder, how do I know that? If I look up in my CM book, N40.1, there is no marking for that. At the bottom of our pages in our CM book, there's actually kind of a fuchsia HCC that will give us those. So if I look at the good charting and I see all of those codes that say none, but over on the top of the next page, 78, E11.9, if I look up E11.9 in my code book, I actually see that E11.9 has the HCC all the way to the right. So those HCCs we can actually pull from our CM code book. Now, a lot of times all we're doing is picking out the codes that are HCCs, and then we have a computer program that's used where those are then pulled. But if you're coding ICD-19s and you're working with patients that are risk adjustment HCC codes, and you're working with MA plans in doctor's offices, a lot of times they will use risk adjustment. So you'll be looking for those HCC codes in your CM code book. So if you don't have your code book with you right there, do go back to your code book and find some of the codes that have HCCs. Almost all of the diabetes codes have the HCC, and it's all the way to the right side of the description of the code, and it's a square box with HCC. Don't get it confused with MCC and CC. This is HCC. So again, these are just some pictures that show how they have the documentation and the computer software that's risk adjustment software where they put those codes in, and it actually determines what that amount is and what that number is for the HCC. You put in the code and it determines the HCC amount. All right, next are our accountable care organizations. These are known as ACOs. These started in 2005. They are population-based models for healthcare delivery. They manage care across the continuum of care. They are usually considered prospectively planned budgets and resources because they usually kind of have a set amount that they're going to pay. Their goal is to provide low cost and effective care, and they are a good size that they can provide good care for a number of people. They usually also include a large number of providers, so it allows them to kind of have more than one doctor and they can provide more care. So when we had the Affordable Care Act, it required that CMS promote the development of ACOs. So they did that, and they came about with something called our Medicare Shared Savings Program. And with this, it rewarded the providers if they could reduce care. So a lot of these came about, and we see them a lot more than what we did before the Affordable Care Act. There is something that goes along with it that's called attribution. This is assignment of a beneficiary to a particular ACO. So this is when you actually are put into an ACO by Medicare. This is figure 4.9. It says 4.8. There's lots of typos in this new edition. This is 4.9. It's on page 80 in your book, so you can see it a little bit better. And that's how they set it up to kind of assign it to you. You can voluntarily sign up during open enrollment. With that Medicare Shared Savings Program, that's that MSSP, it has two tracks. The one-sided risk, this is where if there's a savings, then you share in the savings, but you don't share in the loss. This one makes up about 33%. A two-sided is where you share in the savings as well as the loss. So that kind of makes sense. Two-sided is shared and loss. And this makes up about 67%. And there is an example of that on page 80 where it takes you through and it shows you how to kind of multiply the different amounts. We'll look at that in just a minute. Now, in order to share that savings, they must actually have expenses that are lower than a benchmark. So they have to set a benchmark for how much they want to make in order to make savings or a loss. So let's say that they have a benchmark where they say the benchmark is $3 million and they spend 3.2 million, then in that case, then 0.2 million, they were at a loss. If they made 3.2 million, then 0.2 million would have been a savings. Okay, next is our little patient connection. But before we get there, let's talk about, let's look at our chapter just a minute. I want to make sure I didn't miss any of the examples I wanted to do. All right, let's look at page 68, example 1. Z Company has a health insurance plan for its workers and their families through Wellness Insurance. Wellness Insurance has been contracted with Dr. T to provide health services to members of the Z Company for the capitated rate of $25 per month. So that's $25 per month per member. He is under contract to receive $25 per month for every member. The members of the Z Group total 100. Each month, Dr. T receives $2,500 from the Wellness Insurance for the Z Group. He receives $25 each month, regardless of whether no members of the group see him in the clinic or all members see him in the clinic. Dr. T receives $25 each month, whether all the members receive complex care for treatment or all the members receive simple care for preventative. So remember that capitation, PM, they get the money whether or not they receive treatment or not. Page 69, 2 patients were hospitalized. This is example 4.2. 2 patients were hospitalized with pneumonia. One patient was there for 3 days, the other for 30. Each patient is a case. The third party has established case rate for $3,500 for cases with pneumonia. The hospital would receive a patient payment of $3,500 for each of the 2. So, which one are they going to lose money on? The one that was there for 30 days. All right, let's see. 4.1. Let's look at 4.1. Check your understanding. Check your understanding. Let's check it. So it says, which of the following is not a type of retrospective? So retrospective had 3 different types that fell under retrospective. The 3 different types of retrospective were fee schedule, percentage of the billed, and per diem. So the one that does not is a global payment. Number 2, why is fee schedule reimbursement methodology retrospective instead of prospective? And we talked about that. Remember that it's retrospective because when the patient comes in, we don't know until they are gone how many of those service encounters they had while they were there. All right, what's the difference between bundled and case rate? Remember, they were real similar. Bundled is got a trigger and it follows the pathway. Case rate is a set amount. Okay, number 4, global payment for outpatient. Well, you don't have to create an illustration, but just know that everything is paid for, right? The equipment, the supplies, the drugs, the procedure, it pays for the entire episode. And then what are two criticism of perspective? We talked about the incentives to substitute, less expensive, incentives to delay or deny, premature discharge. Look at that. I did that one. All right, on page 80, let's look at the example 4.3. So Giant ACO participates in a two-sided risk agreement with CMS. So two-sided means it shares losses and savings. With a shared savings rate of 50% and a shared loss rate of 30%. Okay, so whatever savings, they give 50% to CMS. Whatever losses, they give 30% to CMS. Last year, 23,500 Medicare beneficiaries were attributed to Giant ACO. Remember, attributed means that they were assigned to. The target expense for each beneficiary was $12,500. A. If expenditure per beneficiary during the measurement period was $15,000, then what is the shared loss amount? So what it's showing us is the total target. We had 23,500 beneficiaries, and we're going to multiply that by 12,500. That was our number of beneficiaries and our target expense. That's where we're getting that base. And that comes up to 29,375 gazillion there. That's lots of numbers. So what they actually spent was 23,500 beneficiaries times 15,000. There's that number. So what we have to do is subtract that. So 58,75000 is our actual loss. Now, going back to our statement, it says we have to share that loss with CMS. So how much do we owe CMS? We multiply that total loss times 30%. So that's how much we have to give CMS, 17625,000. Okay, down below it says this one is going to be for our benchmark. So again, our total is the same, that 2937500. But in this case, we're going to show a profit. So it only costs $10,000 per person. So 235,000. So we actually made 58,75000. So how much do we have to give CMS? For our shared savings, we have to give them 50%. So we can multiply that number times 50%, and you get 29,37500. So make sure you understand how to do this. There may be one like that on your test, I'm just saying. All right, check your understanding 4.2. So we didn't talk about all the types. We talked about the CMS HCC. When you read through there, you're going to see that there is a prescription one. And there is also a list of all of them. Let's see, what page is that list of some of those others? it's kind of mixed in on page 74 with those. The primary one, they're all set up the same as that CMS HCC. Number 2, how does the diagnosis code utilize to determine risk scores? When we look it up in our diagnosis CM book, we can find the HCC scores. How would the risk score impact the MAPM-PM rate? The PM-PM rate, remember, is where we're paying per member rate. If they have a higher risk, then what's going to happen is that person isn't going to make enough taking care of that patient. If we're only paying the same amount for everybody with an average, if you have a high risk score, then the money's not going to be made for those that are more sick or more at risk for being sick. What was the difference between one-sided and two-sided? Remember that one-sided, you only share savings. Two-sided, you're sharing savings and loss. And then how are the Medicare beneficiaries attributed to the ACO? Remember, there's a term that we use for that. They are attributed to those. So let's look at our little patient connection here. Olivia's pregnant. Her insurance company is the super payer. They reimburse for OB physician group, baby's doctor, with a global payment. Super payment will reimburse baby's doctor's one amount for all care. Figure 4.5. What page is figure 4.5 on? Figure 4.5 is on page 70. Illustrates the global payment for surgery. Recreate and insert a hypothetical dollar amount for the super payer. So here's one that they've kind of done similar to that's on page 70. So they've done all the prenatal visits. Now, I will say this, that the contract is going to determine how many prenatal visits and the charges. There's the delivery. There's the postpartum follow-up. Different vaginal versus cesarean. Remember that amount is the super payer amount. That's how much they're going to reimburse. Reimbursement, of course, is going to be higher for cesarean than it will be for a vaginal. And then also, she will be responsible for cost sharing. Now, she also sees her primary care 4 times a year, and she's enrolled in traditional Medicare, so his office visits are reimbursed via a fee schedule. And this is a sample of a fee schedule. So if you've done 2400 yet, if you're in 2400, when you do your E&M, there are different levels of doctor's visits, and that determines how those are paid. That's the total amount Dr. Lewis will pay. Table 3.2 indicates that Malachi's cost sharing amount for Part B is 20%. So the doctor was a level 2 visit. They charged 46.19. Had a level 2. How much are they responsible for? There's that 46.19 times that 20%. And Medicare is responsible for the 80%. So that's what's called an 80-20 split. We did some of those in our previous. So remember, anytime that it's telling us to go back to Medicare, you're going to see that a good bit where it takes us back to Medicare. And anytime it's given us a dollar amount and it's given us a percentage, we do just like we did last time. That's how much we're going to multiply times that percent. And to multiply times that percent, you can just do, if it's 70%, it would be 0.7. I know a lot of what we did in the last chapter was 0.2, so it made it kind of easy. All right, let's look at a couple of other things in this chapter. All right, this one is in there. Again, make sure you know these key terms. Fee schedule, all of these key terms. We've gone through these. It's got some of the stuff we talked about. Just make sure you know these key terms. All of these are just key term. I really like these little key term slides. Make sure you know. And then that's your little patient there. Here's our ACO. Again, terms, one-sided, two-sided. Make sure that you know those terms. And then our risk adjustment. Make sure you know about that, know where you get that HCC. Here's some other examples. For any of these codes that you see that it gives you an HCC, y'all go in your code book. All you're going to see is the HCC. Without the code, without the HCC software, you're not going to see the actual number. Okay, going in